I was just saying that this is something that I wish I knew more about when I was pre-med, and especially when I was a medical student. And so I hope that I can teach y'all something today. Whoops. Okay. So a couple of things that I'm going to go over with you all is just tell you a little bit about me and provide a brief introduction to what internal medicine is and what a hospitalist is, and then talk about my path to pursuing a culinary medicine certification, and then talking about why do we need culinary medicine. I'll go over a clinical case, which is kind of based on a pattern of patients that I see periodically in the hospital. I'll talk about some evidence-based healthy eating patterns, and I'll explain what that means, some tips for all of you, and advice for your future. And the most important thing that I hope you take away from this presentation is that, you know, you take one point or one tip away to help you improve your eating or help you lead a healthful lifestyle. I really wish that going, you know, as a pre-med, going into medical school, it was emphasized to me the importance of a healthy lifestyle. A healthy lifestyle is the backbone to the treatment of a wide variety of medical conditions. And so I'm here to hopefully inspire all of you to keep that in mind as you enter your respective professional schools. So, sorry, I'm gonna move this. So this is a quote that I often begin my talks with, and I say that it's never too late to start making positive lifestyle changes, and to remind people that really it's progress and not perfection that's important. And this is another few quotes that really resonate with me. So Dr. John LaPuma, he's one of the first physicians that taught a culinary medicine class to a medical school, to a group of medical students. And from his TED Talk several years ago, he said something that really just kind of stuck out to me, that you don't need fancy pants food to create fantastic flavor, and that food is the most important healthcare intervention we have against chronic disease. So a little bit about me. So I am from Texas. I'm from Austin, Texas, and I did all of my education in Texas. So I went to the University of Texas at Dallas many years ago, and I didn't really do that well in undergrad, to be honest with you all. So I decided to take a few years off, and I worked for 2 of those years. And then the 3rd year that I took off, I actually completed a post-bac program at the University of North Texas Health Science Center. And then thankfully, Texas A&M decided to accept me as one of their medical students, and I completed medical school and ended up doing internal medicine residency at the University of California in San Diego. And like we said earlier, I'm actually a hospitalist, and I'll explain what that is, in San Francisco. And I'm currently pursuing a culinary medicine certification with Health Meets Food. So internal medicine, what is internal medicine? So internal medicine, the way I think about it is that we're the doctors that specialize in the care of a wide variety of chronic illnesses for an adult patient population. So we don't see any pediatrics, or we don't see any pregnant women. Internists take care of like heart disease, high blood pressure, diabetes, obesity, chronic lung disease. And then what's really important to remember is that internal medicine is like the foundation for all of these specialties, such as like gastroenterology, cardiology, pulmonary critical care, infectious disease. Sorry, I'm gonna move this really quick. 1 second, y'all. I'm trying to minimize, okay, good, there we go. Had a little box at the bottom that was covering up my words, so I'm gonna move that away. Okay, great. So what is a hospitalist? So a hospitalist is somebody that pursues internal medicine training and actually cares for patients that are admitted to the hospital. So currently I don't see anyone in the clinic setting. I help manage patients when they come in with either a new health diagnosis that they're having trouble with and that they need to be in the hospital, or let's say they have an exacerbation of one of their chronic diseases like heart failure. In addition to actually caring for the patients, a lot of my time during the day is coordinating their care with a team of individuals, and that includes the awesome nurses that I work with, the social workers, case managers, physical therapists, dietitian, and other physicians, especially I'm a specialist. what I love about hospitalist medicine is that I really don't know what I'm walking into. Like no 2 days are the same, and it really keeps me on my toes. So why did I become interested in culinary medicine? So, you know, when I was in medical training, in medical school, and in residency, a lot of my time was spent really learning disease processes and treatment. And unfortunately, at this time, like the norm isn't to emphasize the important aspects of a healthy lifestyle, especially day-to-day eating and how to practically achieve this. And we know this is really important. What we eat matters. What we eat is tied very closely to our health. And then as a South Asian, I'm Indian, and I have a very strong family history of cardiovascular disease and diabetes. And I saw some changes in my own blood work several years ago. And I remember thinking like, oh, well, that's kind of concerning, especially with my family history. And to be completely honest with you, I grew up vegetarian, but I really wasn't a very healthful vegetarian. I didn't like fruits and vegetables. I thought they were kind of boring and that they were something that I just had to like put up with and eat because that's what healthy is. And so every time I tried to do that, or I would kind of fail, it wouldn't be enjoyable to me. It would make me feel like I had to do something. And then there would be times that, I would quote unquote slip up and eat a piece of cake, and then I'd feel really bad about it. And so that's, through my 20s, I had several periods of that where I tried to make changes, but they just weren't sustainable. And so I remember when I saw these changes in my own health, I went online and I'm like, doctor needs to make changes to her health. I Googled something and then like culinary medicine like popped up in some of my searches and through my reading. And so that's, I started reading about culinary medicine and I was like, whoa, this is so cool. Like, why don't we know about it? Why don't we know what it is? So here I am. And this is just a funny, it's not that I don't want to eat healthy. I just have this thing about only eating food that tastes yummy. So that's the notion. That's actually the misconception one of the misconceptions, I should say, that culinary medicine tries to actually combat is that healthful foods are not tasty. That I wish I had known that. I wish I had known how to prepare the healthful foods in a tasty way so that, it would make it enjoyable for me to eat. But I'm happy to say I'm definitely at that point right now. So culinary medicine, the way I like to think about culinary medicine, it's like the practical nutrition, education, and culinary skills. So it's the how-to of healthy eating. It's not enough to tell somebody like, oh, you need to eat healthy. I mean, I've lost count of the number of times I had been told that in my 20s. It's more important to show them how can they eat healthy. It emphasizes like working with what's available to a patient, respecting their, cultural background, their dietary habits, and really working with what they have and how can we improve that. And so it doesn't, dictate a specific diet. It's not, it's the opposite of diet culture. Our goal here is to help individuals really make long-term, lifelong, sustainable changes to their day-to-day eating. And it encourages an overall healthier eating pattern. And I'll explain what that is. The focus is on food, typically cooked at home, because in general, food cooked at home, no matter what it is of a better diet quality compared to, getting it at a fast food restaurant. And how do we practically go about achieving this? And also it's important to focus on, like I said, the pleasures of eating healthier and kind of avoiding these like dichotomous, like good food, bad food type of situations. So when I say dietary pattern, you're going to hear me explain that or say that a lot throughout this presentation. And what I just want to emphasize is that a dietary pattern isn't about, being perfect every day. It's about overall, like what is the like summary or like the generalization of your dietary pattern that you have. So for instance, like some people like to eat more plant-based. So that's, I would consider that like a dietary pattern, right? They're including more plant-based foods and not like a diet in the traditional sense. And it's what you eat like over the totality of your lifetime. Oh, I'm not sure what that was, y'all. So in 2008, the medical costs related to the chronic disease of obesity were estimated to be $147 billion. And then in 2012, the estimated cost of diagnosed diabetes was $245 billion. And, the reason we need culinary medicine is that we have to get away from this, like, do this, don't do this, and really help encourage people to just adopt a healthier eating pattern that's more easily carried out within the confines of what's available to them. And unfortunately, I alluded to this earlier, that there's, large kind of persistent gaps in medical nutrition education, and tying that to health outcomes in our medical training. Most medical schools spend less than 25 hours on nutrition education over 4 years. And what I remember from my medical school was great experience, obviously. Like, I got a great education there, but a lot of what I remember was like deficiency syndromes, like vitamin deficiency syndromes, like vitamin A causes night blindness. But I don't think I've seen that yet in my short career as an attending physician so far. So for me, that wasn't really like, it's important to know, but it wasn't a practical piece of information that I could use to help others and myself make healthful changes. And it's not that we're not willing to learn. I think that, providers, physicians, healthcare professionals, they want to learn how to eat healthier and help their patients eat healthier. But, if they're not equipped with the knowledge and the training, that's going to be a barrier to carrying out this role. And, in order to carry out that role, you do need to have a basic understanding of culinary skills and preparation, also an understanding of behavioral nutrition, including eating habits and patterns. And this all really influences making those healthful changes. And so a lot of health professional organizations and medical schools that have adopted culinary medicine training are really getting their healthcare professionals into the kitchen. And it's the learn first, practice second approach. So we have to teach the healers so that they can help their patients, themselves, and those around them. In addition, like in the US, there's been this kind of increase in eating meals out of the home. And we know that when you're eating meals out of the home, the food is usually calorie dense and nutrient poor. In fact, there was a study done by Smith et al. That looked at a decline, of cooking at home over the last 40 years. And we know that in general, like I said earlier, home cooked food has a better diet quality compared to fast food or eating out. And this was just a graph of the percentage of adults that are eating food out of the home on a given day. So as you can see, when you look at the total number of individuals, like between the ages of 20 to 39, there's, over almost half of individuals that are eating food out of the home. And then I also want to show this graph that looks at the prevalence of obesity over amongst adults, age 20 and over in the US. So it doesn't really matter like what you look at. If you look at men versus women, or the total amount, or all the age groups, the prevalence is above almost, well, I guess here it's a little bit lower than 40%, but almost 40% or above. And then if you look at the prevalence of diagnosed diabetes from like 2004 to 2016, you can see that these like dark blue boxes, the prevalence is higher, and you can see that there's less boxes over here in 2004. And as time has gone on, the blue boxes are definitely more prevalent. And then I'm going to talk about this disease process a little bit later, but this one is really near and dear to my heart because I do see quite a few patients with non-alcoholic fatty liver disease and Nash cirrhosis. So about 25% of US adults have non-alcoholic fatty liver disease. And what that is basically fat deposition in the liver in the form of triglycerides. And the liver doesn't like this. When they see increased fat, when it sees increased fat deposition, it recruits inflammatory cells to the liver to kind of help fight that fat deposition. But what ends up happening is that your liver cells die. And eventually that death is going to be irreversible, and you end up developing cirrhosis, which is considered end-stage liver failure. And this particular entity is, if it's not already, is becoming the leading cause of liver transplant in the United States. And unfortunately, there's no FDA-approved NASH-specific treatments, but I'll talk to you a little bit more about that in just a second. And the reason I'm bringing this disease process up, it really is tied to our lifestyle. The treatment is tied to healthful lifestyle changes. So, you know, there's been a rise in the less healthful foods over the last 30 to 40 years, really convenience foods. And overall, this term falls under the standard American diet, which is all the things that you really see here. And these, you know, this is definitely contributing to the rise in diet-related chronic diseases. So what are our barriers that prevent, you know, individuals or patients, ourselves, from making these changes? So like one of the first barriers, like one of the things that I didn't know is like, where do I start making changes? So like not knowing what changes to make, not knowing how to cook more healthful foods. You're lacking healthful foods in places where one shops. You know, there are places where grocery stores aren't available within a reasonable distance. Some neighborhoods don't have these healthful, like grocery stores to get fresh fruits and veggies, for instance. Perception that healthy food is much more expensive, that it takes too long to prepare, that doesn't taste good. That was like one of my big barriers, and that healthy foods are boring. I don't have time. I don't have the equipment. I don't have the space to prepare healthy foods. I'm so sorry. I don't know why it's not. Oh my gosh, yeah. Sorry, y'all. I had, this is like glitching for me for some reason, but I had this image right here where it actually talks about the complex network of influences on dietary choices and eating behavior. And essentially, you know, eating patterns are very complicated. Let me see if I can just log out and see if I can, if it comes up if I do this. Oh, can y'all see this?
Yes, we can.
Okay, great. So sorry, y'all, that it's really small, but you can see that, you know, food decision making is really a complicated ordeal, essentially. Like you have, you know, neighborhood characteristics, like I talked about, availability of grocery stores, food availability, your income, your education, knowledge about what healthful foods are, food price, the emotional aspects of food, hunger and satiety regulation. So it's very, very complicated. It's not as simple as saying, well, everyone just needs to eat healthier. All right, y'all. So let's go over patient case. Oh my gosh. I think my pictures are out, but that's okay. So this is a typical patient case of mine, or I guess I should say based on a pattern of patients that I see. So let's pretend that you're with me on rounds in the hospital and we're in the post-cardiac surgery unit and we're meeting my patient, Mr. Cardiothoracic. So he's a 66-year-old male. He has a history of diabetes, hyperlipidemia, hypertension, and coronary artery disease. And he just underwent a 3-vessel coronary artery bypass graft procedure, which I'll talk about in just a second. See, Mr. Thoracic actually came to the hospital and he was having some chest pain and they found what's called multivessel coronary artery disease. I think I'm going to exit out of this because for some reason my presentation mode is like not showing pictures. And so I'm so sorry, y'all. This is being very finicky, but I want you to be able to see the pictures. Okay. So what is the coronary artery bypass graft? So the coronary arteries, they come off of your large aorta, which is the big artery that supplies blood to the majority of your body through its branches. And the coronary arteries are some of the first branches that come off and supply blood directly to your heart. And what ends up happening is that when you have blockages in the coronary arteries, you can get chest pain or you can have a heart attack essentially. And so in one of the procedures that can help alleviate the blockages is actually taking other like veins from your legs, or sometimes they take the radial artery or the internal memory artery. And what they do is they bypass the blockages in your native coronary artery, so your actual coronary arteries. And this particular gentleman actually had a 3-vessel bypass. So he had 3 of his coronary arteries bypassed. So I talked about his past medical history, and let me just go back here. So we talked about he had high blood pressure, diabetes, hyperlipidemia, which is high cholesterol, and coronary artery disease. He had his gallbladder out, which is a cholecystectomy. And then of course, he's currently in the hospital with this CABG procedure. And he's on several medications, including lisinopril, which is for his blood pressure, metformin and glyburide, which are for his diabetes, atorvastatin, which is for the high cholesterol, and a baby aspirin. And he doesn't have any allergies. He's a lifetime non-smoker, and he does not drink any alcohol. He's retired and married, and he lives with his wife. And most of their meals are actually consumed out of the home because they're empty nesters, and his wife used to cook more when the kids lived at home, but then they moved out. And so they spend a lot of their time enjoying foods out of the home. And because of the pandemic, he hasn't had much to do. So he's been binge watching his favorite TV shows on Netflix. So let's look at his vitals and lab work. So you can see that I bolded some of the abnormalities for you all. So his blood pressure is 148/89, and that's considered elevated. His BMI is 33.4. And so he has what's called class 1 obesity. So that's between 30 BMI and 34.9. And his waist circumference is elevated at 42 inches. And waist circumference is really correlated closely with the risk of developing cardiovascular disease, because it tells us about abdominal fat, which abdominal fat, especially fat that sits closest to the organs, can be very inflammatory. You also notice on his lab work, he has some, so AST and ALT are liver enzymes, and you can see that his liver enzymes, they're not super high, but they're high, right? So that means that he's had some death of his liver cells, where we're picking up the liver enzymes that live in the liver cells in his bloodstream when we do the lab work. You notice he has a hemoglobin A1C of 7.5, which is considered in the diabetic range, and that his total cholesterol, specifically his LDL, are quite elevated. So you notice that on a prior ultrasound that he had for some other reason, he had some hepatic steatosis. And what hepatic steatosis is actually fat deposition in the liver. And remember, I talked about earlier that the liver doesn't like excess fat deposition. Oops. I'm so sorry, y'all. This is like driving me nuts. So going back to, I showed y'all that image before where there was the liver with progressive fat deposition. And essentially, when you get to the point of the liver cells being unable, they've died to the point that you cannot regenerate the liver because of that fat, those triglycerides, you develop end-stage liver failure. So non-alcoholic fatty liver disease is characterized by the accumulation of fat, like I said, the triglycerides, and it's in the setting of without excess alcohol consumption, because liver disease related to excessive alcohol use is also a common cause or common reason for liver transplant. So 25% of US adults have non-alcoholic fatty liver disease. And of these, 20% have non-alcoholic steatohepatitis. And steatohepatitis means that there is already inflammation in the liver. And remember, we said that inflammation is bad. That inflammation leads to end-stage liver disease. So when you look at that, that's about 3 to 6% of the US population. So it's not a small number. And then Nash cirrhosis is becoming one of the leading causes of liver transplant. The issue with Nash cirrhosis and NAFLD, I should say, there's no FDA-approved medications to treat NAFLD or Nash before it progresses to the end-stage liver failure. And the mainstay of treatment is really lifestyle modification with diet and exercise, and specifically modest weight loss. So if you lose about 10% of your body weight, you are able to actually reverse a substantial amount of the NAFLD and Nash to the point, before it becomes end-stage liver disease. And so it's really, really important for us to identify patients that are at risk of developing NAFLD, Nash, or Nash cirrhosis in order to implement those lifestyle interventions up front. Sorry, y'all. And this is, oh gosh. So I'm just gonna actually, I had an image here. I'm actually just gonna exit out of it completely and not go back to presentation mode because I think it's not letting me, and I'm so sorry, y'all. I did not know that this was gonna happen. Okay. So this is what I was talking about with the progression. So we have a healthy liver, it's nice and maroon colored, and as it fills with triglycerides, you can literally see the fatty deposition into the liver, and it can lead to cirrhosis, like I said. And so while you're talking to Mr. Thoracic on morning rounds, he expresses to you that he knows that he needs to make healthier changes in his life, but he doesn't really know like where to start, and he feels very overwhelmed, which is very common. He's gone through this kind of big hospitalization. He's had major open heart surgery, and it can be a lot to think about. So how are we going to help him? So what dietary patterns of eating can we recommend to Mr. Thoracic for a healthier lifestyle? So these are like the things that I think of when I think of key components of a healthy eating pattern. So really filling at least half your plate with fruits and vegetables. So I always tell patients, like, think about eating the rainbow. Think about incorporating as many different colors of fruits and vegetables as you possibly can. Patients are like, oh, should I do a low carb? Or I love carbs. And so I always say, like, well, great, me too. So, why don't we focus on incorporating carbohydrates that are like made from whole grains? So, that includes limiting sources of refined grains. Like, for instance, one of the easiest changes that I made, not easy, but one of the first changes that I made early on was replacing like all of my white bread or bread made from refined grains with bread made from whole grains. So like whole wheat or whole grain bread. Same with pastas or pastries. Consuming more legumes like beans, peas, peanuts, and lentils. So a lot of people equate the word protein with animal-based protein, or red meat, I should say. And then I always tell my patients, I'm like, look, we have some great, sources of protein that aren't red meat. Like, why don't we think about incorporating some beans instead of like a 6-ounce, portion of red meat? Limiting ultra processed foods, which I'll get into in a little bit. Talking to patients about supplements not being a substitute for real food. I get asked this question a lot, especially with my patients in the hospital. And I bring it up a lot too, because, a lot of our patients are going home on new medications. And one of the first questions that I ask them is, do you take supplements? And if you don't ask, you don't know, because a lot of people, like more times than not, I have patients tell me, yes, I take supplements. And so then, it's really, I do try to spend the time and tease out what they're taking and explain to them that supplements are not regulated. They're not regulated like medications are, like prescription medications or over-the-counter medications. They're not considered, a medication, really. They're considered a food. So they're regulated like food. And you really can't like vouch for what it says like on the bottle with it actually what's in the supplement. So the bottle can say whatever, and then what's actually in the supplement, we're not really sure unless it's tested by a third-party company. And I explain all of this to patients, and they're really surprised. They're like, oh, I had no idea, like they're not regulated. And unfortunately, I've seen patients that have come in with like full-on liver failure from supplement use. And so it can be really catastrophic, and so important for us to bring emphasis to that to our patients. And then don't forget to overlook the calories from liquids. Like that includes sports drinks, soda, fruit juices. I mean, I can't tell you how many times my mom will call and say, I just had Gatorade. It's, it's healthy. And then I'm like, Mom, turn the 32-ounce bottle around and look. And then, she didn't realize, she just didn't know. She didn't think to really look and really understand how to read the label. So that's like even education that I provide to my own parents. And then questions that I try to ask my patients, like, who do you live with? Who cooks for, who does the cooking in the house? Like, where do you get your meals from? Do you go grocery shopping? Do you have a grocery store near you? Do you have a kitchen? What equipment's available to you? You know, some patients may not have a full-on kitchen. Like I've had patients that live in an RV and like all they have accessible to them is like maybe a stovetop burner, or like, you know, a burner that they can put on the counter, and a countertop burner, I should say, and like a microwave. So, you know, all of those things really matter. Like if I tell them to go and bake or like roast some veggies in the oven and they don't have an oven, like that's not very useful information. Do you drink soda? This is like my like number one, like first question that I ask people is, do you drink soda? How much? What can we do to cut that back? Tell me about what you eat on a day-to-day basis. And then I think one of the most important questions is, do you feel like you need to make changes in your day-to-day eating? And I think invariably, most patients tell me yes. And you have to assess readiness for change. So that's one of the questions that I use. So let's talk about healthful eating patterns. So who's heard of the Mediterranean diet? I wish I could have all of you raise your hands so I can see, but I remember, you know, I had heard of the Mediterranean diet, and I heard, oh, I understand the Mediterranean diet is like healthy, but I couldn't really tell you like what it was, how it came to fruition, you know, what the science behind it was. So let me talk to you a little bit more about that. So again, like the word diet isn't really the right word here. So the word diet comes from the Greek word diatia, which means way of living. And so there was an American physiologist who noted that, you know, people and this was like in the 1950s, 1960s, who noted that people that lived like in the kind of the Mediterranean region, in Crete, Greece, and southern Italy, they actually had lower rates of chronic disease and higher than average like adult life expectancy, even though they had limited access to healthcare. And it was believed that there was an association between what they ate and these observations that contributed to their health benefits. And so one of the major studies that actually explored was an intervention trial. So it was a randomized clinical trial, was the PREDIMED study. And this particular study originally was published, I think, in 2013, and it included 7,447 Spanish adults, like between the ages, I think it was like 50 or 55 and 60 and up. And essentially what they did is they told these patients they randomized them to like a kind of a low-fat diet, a Mediterranean diet with supplemented with extra virgin olive oil, and a Mediterranean diet supplemented with nuts. And what they found was that these patients who did not have any history of known confirmed heart disease, but they had risk factors for heart disease, they actually had a lower rate of developing heart disease in both of the Mediterranean diet groups. And what I want you to remember, like about the Mediterranean diet, is that it really is like a plant-forward type of dietary eating pattern. It does include, you know, some sources of animal-based like products, like, you know, dairy products, and what am I trying to say? Like fermented, like for yogurt, I should say, dairy products, not like really milk. It includes, you know, kind of like aged cheeses. It includes smaller amounts of red meat, or I guess red meat is really like a garnishment. It's not meant to be eaten, you know, every day. It includes moderate amounts of fish and poultry, and some amount of eggs. But the majority of the diet, and I think it's better to like look at it this way, is you can see like the base of this Mediterranean diet pyramid really are like plant-based foods, and everything on that kind of builds on that. So it's really, I think it's a great eating pattern. It still includes like a wide variety of foods that can be enjoyed in a tasty way. And in addition to just the healthful eating, you know, the other part of the pyramid, that's the base, is that you enjoy these meals like with your family, friends. You have some amount of physical activity that's enjoyable to you. So it's a great, I think, a great place for Mr. Thoracic or a great dietary pattern for Mr. Thoracic to work up to. And so this is just more evidence that the Mediterranean diet can really help with other parameters aside from just decreasing risk of developing cardiovascular disease. So there's some science out there, or some research or evidence, I should say, out there, that the Mediterranean diet could have a preventative effect on type 2 diabetes in individuals with and without risk factors. and it can improve your lipid profile, so your cholesterol and your blood glucose. Can also perhaps help gut microbiota through the plant-based foods that it incorporates. So a very related dietary pattern, which I like to think of kind of like the Mediterranean diet for the like the American taste, is the DASH diet. So again, it's a dietary pattern, not a diet in your like typical sense. So the DASH diet, the reason this particular dietary pattern came to fruition is that there was a clinical trial many years ago, actually, I should say, that looked at a DASH diet eating pattern for the treatment of blood pressure. And so there were, a group of individuals, like 459 adults, that were randomized to a typical American diet plus more fruits and vegetables, and a DASH diet. And what they found is that those individuals that were on a typical American diet with more fruits and vegetables and the DASH diet had a lower blood pressure, but that blood pressure lowering effect was seen more prominently in the DASH diet, and especially in those individuals that had higher blood pressure at baseline. So this was a really interesting study that was sponsored by the NIH. And what they've also found with the DASH diet, based on other evidence and other studies that have subsequently come out, is that it not only improves your blood pressure, but there's, improvement in risk of developing cardiovascular disease, diabetes, also, lowering your lipids, and possibly with some modest weight loss and improvements in your hemoglobin A1C. And, really both of these are dietary patterns. They're very similar in a lot of ways, in the sense that they include the same amounts of, or same types of foods, but just to varying amounts. So for instance, there's a difference between the Mediterranean diet and the DASH diet based on like the amount of whole grains. The dairy is also different. For instance, in the DASH diet, they include like milk, but the Mediterranean diet, like I said earlier, really emphasizes dairy in the form of yogurt and aged cheeses. The amount of sweets, for instance, that, are incorporated in the DASH diet is probably a little bit more than the Mediterranean diet. But what I've really, I don't want you to get caught up in the nuances of these dietary patterns, but what I want you to notice is that both of these dietary patterns, their basis is incorporating a lot of healthful foods like fruits, vegetables, whole grains, legumes, and nuts. And then of course, there's I have to talk about the MIND diet a little bit too. So the MIND diet is also, it's very similar to the DASH diet. Again, very, with lots of emphasis on, whole grains and fruits and vegetables, and limiting other like cheeses and fried foods and pastries. But what I want to emphasize with the MIND, so the reason the MIND diet kind of came to fruition is that, as you all I'm sure have heard, there's not like a cure to Alzheimer's disease or dementia. And so our focus really is on preventing, dementia from occurring in the first place. And one of the ways that's being studied is that, is through the incorporating or through the MIND diet. So right now there's an actual clinical trial that's going on through, I think it's Rush Medical Center, where they've taken individuals that are, I think, 60 and above who don't have any type of cognitive decline or dementia at baseline, and they've randomized them to the MIND diet versus an alternative diet. And they're looking to see if there's any decreased risk of developing cognitive decline or dementia. So the one difference I want to make with the MIND diet, the foods that kind of the MIND diet emphasizes more so than the other diets, dietary patterns, I should say, are berries and dark, or green leafy veggies. So berries are kind of an antioxidant powerhouse, I should say. They have quite a few, and I'll talk about that in just a little bit, benefits, or thought to have quite a few benefits, especially in reducing the risk of cognitive decline, dementia. And so I'm really looking forward to the results of this trial. I think they're going to wrap up in April of 2021 is what I read. So we'll see. And then also green leafy vegetables, like spinach is like my favorite. I love having like a bag of spinach around and, putting it in everything and anything. So I'll put it in my smoothies. I put it in my pasta sauce last night. I'll, grill it with a little bit of oil and garlic, not grill, but just saute it. with a little bit of oil and garlic and red pepper, and kind of put that on a sandwich. So lots of different ways to incorporate green leafy vegetables. And so I actually have a picture of this particular healthy eating plate on my phone. And I show my patients this, I'll pull it up, when I'm in the room with them, and I'll say, like, look, it's not going to look perfect every day, but, the more variety you have of helpful foods, the easier it is going to be to eat eat healthfully. So if you ate the same thing over and over and over again, like I would get bored of it. If somebody told me to eat an apple every day for 2 weeks, I'd, be like, why? why can't I eat other things? So that's why I say the variety, as much variety as you can, really matters, because it helps you develop your taste palette. It helps you find the things that you like and what you don't like. And that's okay. Like, I don't like mushrooms, and avocado is still growing on me, but that's okay. There are other like healthful foods that I can incorporate that I do enjoy. And I tell patients that as well. And so Mr. Thoracic decides that he would like to try to work towards eating a Mediterranean dietary pattern. And you recommend that he pick 1 or 2 things to change about his day-to-day eating. So especially like the refined grains, like I really go after those because those are very prevalent in the standard American diet. So I'll say, like, look, carbs are not bad. Not all carbs are created equal. Not all fats are created equal. So let's find ways for you to incorporate more healthful sources of carbohydrates like whole grains and helpful sources of fat. And people usually respond very well to that. So a few things to keep in mind. I talked a little bit about I kind of mentioned ultra processed foods. So there's a classification system called the NOVA food classification system, which I think is very useful when you're trying to think of what's considered processed and not processed. It's not perfect by any means, but the category that I always emphasize that we should focus on limiting is the foods that are ultra processed. So, unfortunately, those are things that are very prevalent in our society, like soft drinks, sweet or savory packaged snacks, all the things that you're going to find like towards the center of the grocery store. It's really important, as much as possible, try to limit that. I mean, of course, like, do I like Oreos? Duh, everyone likes Oreos, I guess. I mean, not everyone, but it's considered ultra processed. And then something that I also want to just emphasize, that I have patients ask me if like canned vegetables or canned legumes are considered healthy. And I would say, even though they're in the processed category, like I would argue that yes, they're a great way to incorporate healthful foods into your day-to-day eating. I emphasize, like, please try to get the varieties that are like lower sodium or no salt added, and you can always rinse the liquid off of for instance, like garbanzo beans. Like, I love garbanzo beans, so I always get, I do end up using canned a lot. It's very convenient, and so I'll just like rinse off all of the liquid that it came in to decrease the salt intake. And then let's see, I'm kind of running short on time, so I'm going to keep going. So phytochemicals, what are phytochemicals? So I talked about antioxidants and berries, but in general, like, plant-based foods have a wide variety of compounds called phytochemicals. And these are basically, they're not nutrients, they don't have like a calorie attached to them, but the plant-based foods, or plants, use these phytochemicals for their own defenses against predators and pathogens. And what we've found is that these defense like substances are can be very beneficial to human health. And so, things like beta carotene or carotenoids that make like orange vegetables orange, like that comes from the carotene, and that's an antioxidant that actually has potential health benefits. I mean, this is still all being teased out, like what dose of these phytochemicals, like what the exact mechanism that they have, but we know in general that incorporating a wide variety of plant-based foods it's important, because we do get that type of health benefit from a wide variety of phytochemicals. Whoops, sorry, I'm just gonna. So dietary fats, like I said, not all fats are created equal. The sources of fat that we really want to replace with unsaturated fat or saturated fat. So that's typically in, foods like red meat, also coconut oil. A lot of individuals out there may not know that coconut oil is incredibly high in saturated fat, and it's not something that I recommend as a primary cooking oil. And so I do tell patients that, look, let's find ways for you to replace sources of saturated fat with unsaturated fat. So if they use butter for cooking, for instance, like, why don't we try like a vegetable oil? My favorite is I'm just clicking. My favorite is extra virgin olive oil. So extra virgin olive oil is the main source of fat in the Mediterranean dietary eating pattern. And, I say extra virgin olive oil because extra virgin olive oil is made from olives that are just like pressed, and then like the water and the oil is like separated essentially. And it still retains some of those phytochemicals that I was just talking about earlier, and retains like vitamins. Unfortunately, if the bottle of your olive oil just says like olive oil on it, it's a refined olive oil, so it's gone through further processing. And so that processing actually can remove some of those phytochemicals and vitamins. So I know that extra virgin olive oil is like definitely a pricier oil. And if my patients are able to incorporate that into their day-to-day eating, I always recommend getting it from places like Costco, because you can get like a 2-liter bottle for like $15, and it'll last you for a lot longer than getting like a smaller bottle from like a typical grocery store. And then avocado oil is also another one that's very popular that people use primarily for cooking. I will say that there was a recent study that was done at UC Davis that looked at different brands of avocado oil, and they really found that there was only like 2 reputable brands that actually had non-rancid avocado oil, and that included Chosen Foods and Marianne's. It's not sponsored, like I'm not sponsored by these. I'm just saying that like avocado oil, unlike extra virgin olive oil, is not as, there's not a lot of like third-party testing. So for both, for extra virgin olive oil, I do look for the bottles that have, I do look for the brands that have like a certification seal, but that doesn't really exist for avocado oil right now. And so like based on this study, I guess there's only really, but they only found like two specific brands. And I know that they sell Chosen Foods at Costco. And then, people always ask me about other cooking oils too. So I always say that I rather have people use whatever cooking oil is available to them if that helps them eat more plants. So, a lot of people have differing opinions about canola oil, and I say that if you're able to replace, a source of saturated fat like butter or lard with a vegetable oil that you can, reasonably afford, such as canola oil, which is, much cheaper than avocado oil and extra virgin olive oil, and that's going to help you eat more healthfully, then I would say that, it's a good plan. And so you really have to ask yourself, like, especially in nutrition science and in medicine, like, what is the comparison factor? If my patient eats less butter and they can, hopefully help their high cholesterol because they replaced it with canola oil, like I would call that a win. So definitely ask yourself, in comparison to what is this going to be better? Also examples of whole grains. So I keep talking about whole grains, but let me explain to you all what that is. So when you have a whole grain, it contains all 3 components, and that includes the bran, the endosperm, and the germ. And you can see that the bran is the outer layer, and it has like the fiber, and fiber is very, quite important for our health. And when you when you refine the grain, I should say, the bran and the germ are removed. And so you do lose the fiber, the vitamins, minerals, phytochemicals, and you are just kind of left with this starchy like middle layer, which does get some proteins and vitamins. And a lot of refined grain products are like enriched, and so they add like the vitamins and the minerals back. But that's why I say to people that, look, let's figure out what grains you're eating. Let's see if we can, incorporate some whole grains or swap out some refined grains for whole grains. So one of the things that I've done is like I've replaced all of my white rice with brown rice. I also really love quinoa, and bulgur is actually a really great whole grain that not a lot of people know about, and I'll be doing a post on it soon. But there's different options. Of course, some of these can be pricier than others, and I I definitely look at the cost of food when I'm making, when I'm thinking about healthful eating and making recommendations. And for me, like for instance, like again, I'm not sponsored by Costco, I promise, but quinoa has been like, that's where I've had the better bang for my buck for quinoa. And then I also talk about, the whole grain stamp, which is useful if it's available on the product, but some whole grain products or grain containing products may not have the stamp. So, but if when it's there, it's useful, and I'll leave that for y'all here. I also made a quick blog post on what to consider when choosing grocery store bread. And then just quickly, because I think this is so important to know, is that when you're reading a nutrition label, like the serving size that's listed on the label is not a recommendation of how much to eat or drink. The serving size is based on how much people are actually eating or drinking in the US. So for instance, like the serving size of soda increased from 8 ounces to 12 ounces. But that doesn't mean that we should just go and drink 12 ounces of soda because that's what the serving size says. That just means that we're, as a society, that's how much soda we're drinking. And then I think like some of the serving sizes for certain like fruits and vegetables decreased a little bit, but that doesn't mean that you should limit yourself to that serving size. It's really, a serving size is important to compare products next to each other. So like if you have 2 cereals or something, it's useful to compare like the other nutrients and the other components of the nutrient label. And then I think a chef's knife is for me was like game changing for healthful eating, because it was just like so much more fun to cut fruits and veggies, and it doesn't have to be anything that's super expensive. I got this was my first chef's knife, and I think I got it for $20 on Amazon, and it worked really well for me for a while. My friend actually bought me a pretty fancy chef's knife, and now I just like love cutting with it. And I, make sure it's like well taken care of. And then how to actually properly hold a chef's knife and cut fruits and veggies and other foods is really, to me, it's like super fun. I have a couple of posts on my Instagram on how to keep produce fresh, which is, I think, really important. So I've kind of, if you go to my Instagram, you'll see these posts and you can check them out and learn a little bit more. Another produce storage tip, and then preventing food waste. Can't tell you how much food I've thrown away because I didn't know what the printed date actually meant. And so it's really important to understand that, because you can really make your groceries last longer, which makes it easier to eat healthier. If you're new to cooking, I also wrote a blog post on just some of my tips. And then I think we're like running out of time, so I'm leaving a few of my culinary medicine tips, but just the takeaway is think of one thing that you want to change today in your day-to-day eating. Start somewhere. It doesn't have to be perfect. It's not going to be perfect every day. It's, I have my days where like people ask me, do you eat dessert? And I'm like, of course I eat dessert. I'm a human being, but I definitely have my days where, things like, especially when I'm working and it's a really, really, really busy week for me, I give myself a little bit of grace and flexibility, because, I don't want this to ever feel like it's a task or this big mountain that I got to climb. I've made these changes sustainably for the last several years, and I'm going to continue making changes as I learn. And I just have to be, patient with myself. And that's what I encourage for others as well. And then, sorry, I know I have so much in this slide set, but like the one thing I always kind of end my presentations when I talk about culinary medicine is that, I talk a lot about food and its connection to health, but then there's also a connection with healthful foods and our environment. So some of the foods that, we try to limit in our day-to-day eating are actually very taxing on our environment. And so you can see things like certain red meats, chocolate's up there, y'all, and cheese are actually very resource intensive from our environment. And other foods down here, especially legumes. Legumes are very environmentally friendly in their production. And so, not only is eating healthfully important for your health, it's also important for the health of our planet. And then just advice for your future. Like I said earlier, y'all, like I did not do very well in undergrad. I had a medical condition that I was diagnosed with my freshman year, and I didn't do very well. I had my grades really like slip and fall, and I thankfully was treated appropriately and was able to recover as far as like making better grades from that point onward. But I mean, it really was hard for me to kind of climb out of that hole. And I also didn't do very well on the MCAT. So it was like, yeah, the odds were really stacked up against me. And so that's why, you know, I decided to take a few years off and really work on my own timeline and apply to medical school when I was ready. So I always tell people, don't feel a pressure to apply if you aren't ready. There were so many people around me that were applying, and I was like, why am I not applying? Like, should I apply? And I'm so glad I didn't. And if your undergrad wasn't, you know, the best as far as grades, then consider doing a post-bac. Definitely take your MCAT early, especially if you live in a state like I did, Texas, with rolling admissions. You know, as people send in their applications earlier, there's more interview spots that are available. And so especially if you don't have the best like statistics, it's important to get your application in as early as possible, because later on in the season, there's less interview days, less interview spots. And so medical schools might be a little bit more stringent on their criteria. And then take the MCAT early, and then start to identify potential letter writers like ASAP. You know, when you're a freshman, like think about building those relationships with your professors, like do research with them, really allow them for a chance to get to know you, because you want a letter writer that really knows you, knows your skills. And so start that process as early as possible. And then just remember, go to medical school for you. Don't do it for your parents. Do it for yourself. And then thank you so much, everyone, for listening. As I'm very active on Instagram at drplantel. And then I just want to let you know that I am having an Instagram live with one of my fellow culinary medicine colleagues, Dr. Disha Narang. She's an endocrinologist. I think she's presented on socially distant shadowers before. That's going to be at 6 o'clock tonight, Central Standard Time. And then tomorrow, for all of you that have Clubhouse, myself and several of my physician colleagues that are interested in healthful nutrition are talking about healthful eating on a budget. And so that's going to be tomorrow, Thursday at 8 p.m. Eastern Standard Time. All right, guys, I said a lot, and I'm so sorry that my presentation wasn't working, but I wanted y'all to see the pictures, so that's why I had to cut out. What questions can I answer for y'all?
Thanks so much, Dr. Patel. This was awesome. Everyone in the chat was just amazed. Like, there's so many things that you just, like, myths that you busted for us and gave us such good information. So thank you for that.
Of course.
I guess we can just do a couple of questions. And of course, if anyone has any other questions, head over to Dr. Patel's Instagram. So there was a question that came up several times, and it was asking about what you recommend, or if you recommend at all, probiotics and how you implement that into your patients' lives.
Yeah, so I actually don't recommend probiotics. The data for probiotics is really not there. And the American Gastroenterology Association actually had, I think, a recent statement that they placed on probiotics. So to be honest with you all, I don't recommend it on any level of my patient's care. Like I said, you know, it's important if you are somebody, after speaking with your physician, that takes probiotics, making sure you take it from a reputable source. So yeah, no, I don't recommend them periodically.
Awesome. Thank you for clarifying that. That's good to know, because I was under the impression that you should. So we had an interesting question earlier on asking about what the difference between, you know, getting your culinary medicine certification and being a nutritionist or a dietitian is.
Yeah, that's a great question. And I would say that, so a registered dietitian goes through extensive training to become a registered dietitian, and they really are the experts when it comes to nutrition science. The part that I think culinary, and you know, dietitians also can pursue culinary medicine training. The part of culinary medicine that adds to nutrition science is the practical culinary skills, and the culinary skills is huge. And then also tying all of that back together with how everything, how the way we eat affects diet-related chronic disease. And so I wouldn't view it as like one or the other. These are all, like I work, closely with registered dietitians. Like I can't do it all myself, I really rely on them to help me with my patients, especially with our quite ill patients that have different, like for instance, protein requirements. And so we work together. It shouldn't be viewed as one or the other. And when it comes to nutrition science, our registered dietitians are the experts. Now, nutritionists are, that's kind of a lot of people think that nutritionists and registered dietitians are the same, but, certain people may call themselves a nutritionist, but it's important to clarify, are they also a registered dietitian, or did they get a certification? And that's why I always say it's important to clarify people's credentials that you're, listening to for advice or following on social media, because fortunately right now, a lot of misinformation, not just related to the health and nutrition field, but just in general, is rampant. So important to know who's giving that type of information.
Awesome. Thank you so much. I guess we can maybe do like one or two more questions.
Sure.
Real quick. Another interesting question that someone asked that I would also be interested in knowing is, so there's been people who've said like it's not safe to microwave your food, or that you lose nutrition after you microwave your food, like reheating food. Are there any truth to that? Or like what you recommend, I guess, in reheating food?
I would say that I'm not aware of like some like substantial studies that show like big differences in like nutrient composition or vitamins and microwave. I don't know of any studies, to be honest with you, and it's not a part of that I've looked into specifically, but I will say that it's important to follow like good food handling practices. And so, microwaving your food to an adequate temperature for consumption is very important. And I'm not aware of any studies that show some substantial like nutrient quality detriment with microwaved food. In fact, sometimes my patients, all they have is a microwave. And so, if that means that they get bags of steamed vegetables and put it in the microwave and that's how they can eat their vegetables, that's great. I'm all for it.
That's great. Thank you so much for answering that and clarifying that for us. I think we can wrap up with this last question. Do you have any last piece of advice for us as pre-med, post-bac, masters, all that, students still navigating through the pandemic that's going on, especially for those of us in Texas?
Yeah. Don't listen to the naysayers. I can't tell you how many times I've had individuals tell me that they're like, there's no way you'll get into medical school. And I'm so glad that I kept pushing forward and I didn't let anybody deter me from that path. It's a rewarding career so far. I do want to say that it's important to really understand why you're doing it. It's a challenging path. It's not easy. You dedicate your 20s to training, to working hard, to studying, to missing birthdays and weddings and family gatherings. And if you're doing it because somebody else told you to do it, or you feel pressured to do it, it's not going to be enjoyable. It'll make you miserable. And so I always tell people that, yes, my parents, were like, oh, my mom especially was like, I hope you become a doctor. But that's not why I went to medical school. I went to medical school because I really, truly had a passion for wanting to help people better their lives. And, my culinary medicine passion obviously came after medical school, and that's okay. Things really fall into place when they're supposed to. But just really think about why you're doing it. And if this doesn't actually make you happy, and the thought of, being a doctor doesn't make you happy, then it's, to me, not the path for you. And there are other ways to make an impact in this world, and that's okay.
Thank you so much. This was awesome.
You.
in the chat, you can kind of see all the thank yous and
Oh, great.
all the nice comments that people have been sending in. We hope you have a great rest of your day. Thank you so much.
Thank you. Yeah, it was so fun to be here.